Hello, I'm here to present on my first live observation, which was in a medical setting. And I wanted to describe the environment by showing this little diagram. So coming in the door down here, I was here observing. I was standing at the head of the examination table. The deaf person was at the bottom of the table. Over here is just a counter, a couple of chairs, and then the door was closed obviously when the doctor came in, and the doctor and the interpreter were standing beside each other. So it's essentially your regular examination room, doctor's appointment environment. So the general goal of the environment would be healthcare, and the goal of the setting in particular for the deaf person was to update the physician on a number of her medical conditions. And naturally, the doctor was there to treat any conditions. So the participants included the white deaf patient, a woman about 50, ASL dominant, signer, functionally literate in English, a white doctor, about 45. Terminology for the environment included medication names, medical procedures such as MRI, CT scan, X-rays, a number of things along those lines. As well, there was terminology that included anatomical vocabulary such as the ulna, and then general terms around skin conditions and fatigue and things like that. Okay. While we were waiting for the doctor to arrive, the deaf person was very gracious, allowing me to observe. Was very chatty. In fact, we had met, she and I, before, so she was giving me a long update on a trip she had taken to another city and so on. So she was quite engaged in conversation and dominating the conversation until the doctor came. The interpreter coming into this assignment had wonderful controls for this particular environment. She has 25 years or so of interpreting experience. She has her AVLIC Certificate of Interpretation, what we call the COI here, and in personal communication with Marty Taylor, she has indicated that the AVLIC COI is equivalent or greater than the RID Masters NIC. The interpreter was a woman and of similar age background as the deaf consumer. So the interpreter is very much a competent bilingual. Once the doctor arrived, I was able to observe the interpersonal dynamics of the setting. It appears the deaf person had been going to that doctor for some time. He had quite a history with her. And the deaf person wanted to thoroughly review a number of medical questions and procedures and confirm certain information that she thought she understood. So she had quite a long list of things she did want to cover. When the actual interview got going, and this is something I touched on in my post on Blackboard, that this particular deaf person had been to a neurologist, had been to a dermatologist, had been to a 3-day workshop on fibromyalgia, how to live with it, how to manage it, how to exercise, what things you should do, what can aggravate it, that kind of thing. She had been to a sleep lab, which was over a few days. She had been to an occupational therapist, and she had had a fall. In fact, I believe the actual story is that she was mugged, and which she was pushed as a result, and her ankle was twisted, and she fell on her arm and hurt her arm and hurt her ankle. So she was trying to get fitted for some arm brace, and that came up in this meeting or in this interview about how uncomfortable what that was, and she wanted to talk to the doctor about arranging to order an arm brace online. So those were kinds of the various appointments she had gone to, pardon me, that she wanted to update the doctor on, and she had out there on the examination table, pardon me, excuse me, um, she had set all her medication down on the bed so that she could be prepared when the doctor came in to discuss each one. So while the interview was going on, she was explaining much of what had happened, where she had gone, what she was doing. The doctor wasn't really taking notes, and he did have, it was apparent, he did have some reports back from these various appointments. I'll just sort of demonstrate how the dynamics went on by talking about how she went through each of the medications. And for instance, she had some pills that had been prescribed, and she said, now this is for that, and explaining to him what he already knew. She got some cream from the dermatologist, and she had said, but it said it was supposed to be liquid, but look, it's a cream, it's not liquid. So he's trying to negotiate some of that information in terms of cream kind of pouring is liquid for that context. It's not a paste, for example, or it's not a gel. I mentioned earlier that the deaf person was functionally literate in English, and the reason I surmised that from what I observed is because she was referring to material that she had read. For instance, the material about this cream being liquid, and she saw that it was a cream, not a liquid like you might think of as water being a liquid. But she also had some instructions about how to apply it, and so she was going through these instructions with the doctor about putting her arm in warm water and leaving it there for 5 minutes, and then patting it off and drying it, and then applying the cream. So she was going through this, and in my mind, when I was observing that, I was recognizing her language being from a low context communication culture where that kind of detail is given as a natural part of the discourse, and that was not didn't necessarily fit into this particular context with explaining to the doctor the instructions about how to soak your arm before putting on this cream. Another example of that that demonstration of her low context communication style was explaining how in the 3-day workshop on fibromyalgia, she was taught to do some exercises and talked about walking and how she was supposed to, and the others and the participants in the workshop should walk, I forget the specific distance, but walk this distance. And so she was started to saying that she did more than that, and now her feet hurt, and the doctor was just starting to become impatient. He just, said, well, don't walk so far, kind of idea. So this was the dynamic I was observing, the interpersonal dynamics I was observing in this appointment. The deaf person giving lots of information, asking questions, checking her understanding of things, and the doctor under the discourse style of being to the point, factual, time constraint. So there was a demand there for the interpreter, and I'll talk a little bit more about that. I just want to finish off with a few more comments about my observed interaction between the doctor and the patient. So as I said, the doctor started to demonstrate signs of impatience with his breathing, kind of sighing like that, nodding, writing down some things occasionally just to make sure he got a fact, but nodding his head and kind of sighing, and what I would interpret as signals to move it along. At one point, she was talking about her hand being sore, probably from the fall. And in fact, the doctor, and so she started to describe it a little bit more. And the doctor cut her off and said, "Okay, I'll send you to a specialist." And he actually said hand specialist. He didn't give a technical term. He just said a hand specialist. And the the underlying implicit meaning for me when I saw that was that he wanted to stop her from explaining more about the pain or more about the issue. He would send her to a specialist. And then at the conclusion, the same, typical kind of wind down. Okay, well, we'll do this and come back in a month. And actually, when the doctor left, he closed the door rather loudly. I don't know that he meant to do that, but it was louder than you would have expected in a doctor's office. So with that general context of what was going on, I'll go now more specifically into the two main demands and talk about those. So as I discussed the interpersonal dynamic between the deaf person and the doctor showing impatient at the deaf person's extensive list of topics to review, and as I said, he at one point cut her off, but was giving other signals to move it along. What I observed in terms of control decisions for the control responses for the interpreter were to work simultaneously. She was going from English to ASL. She was signing quickly. She was demonstrating message equivalent. I would suggest message equivalent emotive grammar and facial grammar. So, for instance, when the doctor was nodding, said, "I know that." The interpreter was going. She wasn't going. She was being. She was reflecting the doctor's impatience. So on the flip side of that, that's when she was working from English to ASL as an example of showing his impatience. And so the flip side of that, I'm kind of rolling the dynamic of the two together in describing this main demand. So the ASL to English, when the deaf person was going through, well, this is the medicine the neurologist gave me. Do you think it's okay? Is that, do you, basically she was asking, do you approve? And again, the interpreter is working simultaneously. And she was using several transition phrases that I would suggest would be normal for English speakers in terms of, well, I just wanted to check in with you. I got this medicine from the neurologist. Do you have this on your files? That's not exactly what she said, but she was using transition phrases like, I just wanted to check with you. This is what I was thinking. I wanted to find out if this is right. So those kinds of things that link all of these questions and this list of questions and material that she wanted to share with the doctor in a way that was cohesive, as well as, I thought, a good, efficient fit with English discourse style. And I actually wanted to bring into this discussion something I read just within the last week, and that's Napier, 2002. And in this article, she says, she talks about managing the turn-taking sequences with a knowledge of the linguistic and social meaning beyond what would be apparent to consumers. So when I read that and I watched this interpreter work, I felt that I saw the management of the turn-taking sequences demonstrating linguistic and social meaning between these two consumers. The deaf person was working from the low context communication discourse structure, and the interpreter still needed to deal with that. She couldn't compress everything. When the deaf person is showing her arm down in the water, or lifting her foot up to show where on her foot it hurts. There's certain things that you obviously need to interpret because they are so self-evident. And the doctor was working from that time-constrained, direct and factual discourse structure. So as she managed the interaction, I saw her knowledge of the linguistic and the social meaning in that work. So it was a wonderful experience. Definitely because the interpreter had a great deal of experience with this deaf person's medical history. She had been involved in some of those appointments, those previous appointments. So her interpretation was very effective content-wise. When I looked at some of the ASL source language and then I heard the target language, I saw a perfect match, but I knew that if it had been me, I would have needed more context, because when the deaf person was doing something along these lines, showing her arm, the interpreter knew she was referring to the ulna. But as a new interpreter without the context, I wouldn't have had that, I wouldn't have been able to be that specific without more clarification and without taking more time up in the interview. The other main demand I wanted to talk about was the interpreter's intrapersonal demand of the deaf person being so talkative. And during our debriefing after the appointment, the interpreter told me that she went in and she did do the control of self-talk, saying, you know what she's like, you know she likes to take a long time to explain things, you know she likes to repeat. It's not on me, the interpreter, it's not on me, it's their relationship, it's not on me. So she actually went through a series of phrases for herself to prepare, to mediate or to manage the interpretation, but at the same time know that she should be prepared that this could take a long time and that she could irritate the doctor and she would maybe be a little long-winded. She even expressed that during the assignment, when the deaf person was saying, this is the medicine that the neurologist gave me, what do you think, or is this okay, was how the deaf person was interacting with the doctor. And the interpreter said she had a demand raised to the level of significance that said, of course it's the right medicine, the neurologist prescribed it, in her head. And then immediately went into the self-talk. This is the deaf person's appointment. This is what she wants to make sure about. So got back on track with the self-talk as a control response. I do want to just tag on to this, not part of the doctor's appointment, but out in the waiting room, the deaf person remembered, oh my goodness, I forgot to ask him to fill out this police report. And so she needed to make another appointment. And the appointment time was not a time that this particular interpreter was available. And so as a result, a post-assignment control for this interpreter was going to take was to contact the agency and let them know to expect the deaf person asking for an interpreter for a future appointment, and that interpreter could get a hold of her to get some more context, because the whole scenario was so complicated around the mugging and who was involved in the police and all the medical follow-up as a result, that it would be much more efficient for the interpreter and the consumers if the interpreter going into the next appointment had some more context. So that's where there was that additional that I wanted to raise here, post-assignment control in terms of ensuring that the next interpreter and the agency knew a follow-up would be happening. So in my general observation, the controls the interpreter brought to this assignment were very effective. both experience-wise, skill-wise in language, but also skill-wise in interpreting and managing the setting. I believe each consumer left having achieved their respective goals and having had a genuine experience of the other. When the interpreter and I had the opportunity to debrief afterwards, it was a wonderful experience. She was not very familiar with demand control schema and had certainly read about it, but it wasn't really understandable to her the way the articles that she had read. So we went through these very topics in demand control schema terminology, and so that was a very rewarding experience for both of us, I believe, and will lead to more professional discussions in future. So I'm just going to review my notes just briefly to make sure I have not missed any important points. There were no paralinguistic demands. The hearing and the visual access to the language was not a difficulty. No, I think that covers my experience with this particular medical appointment. Thank you.